Hello, my name is Jack Miller, one of the co-directors of Key Clinical Skills. KCS Connects is our way of helping to connect you with some literature that we believe will be of value to you in your clinical practice. This issue of KCS Connects looks at a recently published paper from the Journal of Orthopedic and Sports Physical Therapy. The researchers were from Baylen College in Wisconsin. And the question they asked was, do maladaptive imaging beliefs predict self-reported pain, interference, and physical function in patients with musculoskeletal disorders? Now, a bit of background here is that the right to order imaging by Canadian physiotherapists is rapidly expanding. Currently, we have the right to order imaging in the provinces of Alberta, Quebec, Nova Scotia, and Prince Edward Island. And the process is in development in Ontario, New Brunswick, as well as Newfoundland and Labrador. Now, a common belief with patients about imaging include that it's needed to rule out serious conditions, and clinicians can't guide treatment plans without having seen the body structure first. And accurate diagnostics cannot be determined without imaging. Imaging is required to validate their symptoms. Now, the background about the data, though, is the exact opposite. So here's the British Medical Journal guidelines for imaging about uncomplicated low back pain. And what they state is that less than 5 to 10% of all back pain is due to a specific spinal pathology of any kind at all. And imaging may actually do more harm than good. Now, a published paper in 2020 by Sharma looked at the clinicians' and patients' belief about imaging for back pain, and it's a systematic qualitative evidence synthesis. And they looked at 60 studies with over 1,700 subjects. And the findings here is that the patients and clinicians both believe that diagnostic imaging is a useful test for locating the source of non-specific low back pain. They believe that diagnostic imaging has multiple benefits and minimal harms. Patients with chronic low back pain believe that the pathoanatomical findings on diagnostic imaging provide evidence that their pain is real, and they don't find that the absence of serious pathology on imaging is reassuring at all, though. Whereas the clinicians in primary care believe that ordering imaging reduces the risk of misdiagnosis and litigation, but the absence of serious pathology on imaging would reassure the patient. But again, as we just said, that's not the case at all, is it? Now, this particular study looked at 152 patients with musculoskeletal disorders who were seeking care from a physiotherapist. And they measured the maladaptive beliefs on need of imaging to rule out serious pathology, guide treatment planning, determine the diagnosis, and validate symptoms. And this was measured using 4 questions that were trialed in a pilot study. Their findings were, first of all, that 61%, 93 of the participants, had at least one maladaptive belief. 16 had 1, 21 had 2, 24 had 3, and 34 had 4 of these beliefs. Most common of these maladaptive beliefs was that, quote, in my case, I think imaging is needed to determine the cause of my problem. Now, conclusions here is that, first of all, maladaptive imaging beliefs were significantly correlated with pain and physical function. Each additional maladaptive imaging belief increased pain interference at 6 weeks and lowered physical function at baseline as well as 6 weeks. And these beliefs about the necessity of imaging to properly manage musculoskeletal disorders will significantly influence your clinical outcomes. So as diagnostic imaging rights continue to expand in Canada for physiotherapists, the utilization of diagnostic imaging really does have to be placed in the appropriate clinical context with a detailed history, a thorough physical examination, sound clinical reasoning. Now, if you'd like to learn more about diagnostic imaging for physiotherapists in Canada, come visit us at www.keyclinskills.ca, where we have our diagnostic imaging for physiotherapists 4-part series: foundations, spine, extremities, and utilization. These are all distance learning, self-paced, over 60 hours of content, clinically relevant, with downloadable handouts. So the question we ask you, are you ready to work to the top of your scope? Hope this helpful to you in your clinical practice. Come on back to Key Clinical Skills for more great learning.